Hotbed Talk.
Thanks to the organisers of EBPOM for this invitation to come and talk about the summary results of the SNAP-2 EPICCS project. And in particular, given the circumstances that we all find ourselves in at the moment, I think it's useful to reflect on what SNAP-2 EPICCS might offer us in the brave new world that we find ourselves in with coronavirus here, probably to stay at least for the short term. So, what has SNAP-2 EPICCS, the study, told us that we didn't know before? This is what I'm going to go over in the course of the next 25 minutes or so. So the first thing is the scale of the problem that we had and probably still do have with the cancellation of inpatient surgery and the rates and reasons for cancellation of inpatient surgery with a specific lens on critical care capacity. The second thing is what clinicians think about the value of higher levels of post-operative care for high-risk surgical patients. So what they think the essential ingredients are of a higher intensity post-operative level of care. The third thing that we're going to talk about is some of the organically developed solutions that have come around to capacity issues for high-risk surgical patients in the NHS and indeed overseas. Fourth, we're going to think about how we might select patients to be admitted to higher levels of care. So going over the methods that we might use for risk stratification of inpatient surgical patients. And then the final piece of the puzzle is what we think the potential benefits of post-operative high levels of care could be. So do we have any data to support the notion that critical care confers benefit on high-risk surgical patients? So to remind you, the SNAP-2 EPICCS study took place in 2017 and it looked at the epidemiology of critical care after surgery. And we took on the study because we reflected on the fact that at that time we had quite a significant problem with critical care capacity in the United Kingdom and indeed abroad, and that we felt that that was likely to pose a risk to high-risk surgical patients. And one of the things that we observed from national audits, studies such as the ISOS study or the USOS study, and also things like the National Emergency Laparotomy Audit and the EPICCS study, is that although we have a threshold for admission of patients to critical care of a predicted 30-day mortality of 5% or greater, we know from these studies that that is not consistently applied, and there are quite a few surgical patients who would fall into the category of needing to be admitted to critical care who are not. And the reason for that, I guess, is probably obvious to those of you who work in critical care or in perioperative care. On a day-to-day basis, the consultant and the nurse in charge of the critical care unit will have to referee this battle that there could be between the surgical patient and the medical patient. The surgical patients on the whole are planned. Obviously, there are some emergency cases as well, but you at least usually have a few hours' notice of a surgical patient wanting to be admitted. But then also coming through the doors are the acute medical patients who might require urgent admission to critical care for a variety of reasons, and therefore on the whole would probably trump surgical patients if there was a shortage of beds. And of course this year we've got this new threat, the threat of coronavirus. In the United Kingdom we've just lived through hopefully the only surge, but certainly a very significant surge demand within the NHS as a result of coronavirus. And what has that taught us about UK critical care? Well, the first thing is that we have such a lot to be proud of because the NHS and critical care, perhaps in particular, has demonstrated itself to be enormously resilient and adaptable. And one of the things that we've recognised is the fact that we can rapidly expand capacity in the case of a surge, in the case of this massively increased demand that we saw over March and April. But that comes at a cost. And of course, the reason that we were able to expand critical care so quickly was because we put a pause on much planned surgical activity. So going forward, we're going to have to manage in a COVID world, both COVID and non-COVID pathways for patients coming in for surgery or indeed just coming in through the doors of the emergency department. And therefore COVID and non-COVID patients, aiming to reduce any risk of nosocomial infection with COVID or anything else, and accept the fact that that may sometimes mean that services are less efficient than they would otherwise have been. So that's the brave new world in which we find ourselves. So going back a couple of years now to when we did SNAP-2 EPICCS, the three things that we wanted to achieve through the study were these. The first was to analyse the epidemiology of critical care after surgery. The second was to engage clinicians in research using a citizen science approach. And the third, very importantly to me, was to support trainee leadership in the delivery of a major international research study. So what we did, the study had 3 parts. It had an organisational survey where we tried to understand the way in which critical care is provided to surgical patients. The second was we undertook a survey of clinicians, so anaesthesiologists, surgeons and intensivists, to understand what their perceptions were around the management of the high-risk surgical patient and post-operative critical care facilities. And then the third thing that we did was a patient recruitment study, which took place for a week in each country that took part, and the 3 countries were the United Kingdom, Australia and New Zealand. So the first major output of this study was a paper which looked at the rates and reasons for cancellation of inpatient surgery in the NHS. And it was a 7-day cohort study in 245 NHS hospitals, which accounts for about 93% of acute NHS hospitals in England, Wales, Scotland and Northern Ireland. And we undertook 2 main analyses for this paper. The first was a hospital-level census looking at the number of cancellations and the reasons for those cancellations on a daily basis, and that included elective and emergency cases. And then the second was that we looked at individual patient analysis of those patients having planned surgery to look at the risk factors for previous cancellation if that patient had been previously cancelled. And we found the summary results that there was really quite a significant burden of cancellations. So the hospital level census yielded that 1 in 7 patients attending for inpatient surgery, whether that was elective or emergency, were cancelled on the day. And the patient level data told us that about 10% of patients attending for planned inpatient surgery and having their operation during the week of the study had been previously cancelled at least once. Looking at the reasons for previous cancellation, we identified that about a third of patients were cancelled for clinical reasons. And it's a regret of mine that we didn't record whether those clinical reasons were unpredictable or potentially predictable. So unpredictable might have been an acute infection at the time of surgery, which merited therefore cancelling the case. Potentially predictable reason would be, for example, not stopping drugs which should be stopped before surgery, such as anticoagulants. And in the future, we would certainly want to be able to unpick those sorts of things. And interestingly, within the NHS, although we collect data on last-minute cancellations, we only collect the data on the patients who are cancelled for non-clinical reasons. So understanding the clinical reasons for cancellation at the last minute is important when thinking about the whole pathway of perioperative care and whether anything can be done to reduce that last-minute risk. The non-clinical reasons for cancellation predominantly related to capacity, so lack of beds in the hospital, insufficient operating theatre capacity, so running out of time in theatres, and a handful of other reasons as well. If we look at this graph here, it shows us the patient-level adjusted reasons for cancellation. So, first of all, the good news, which is the patients that were the least likely to be cancelled are probably the ones that we really, really wouldn't want to be cancelled. So, those having cancer surgery, those having expedited surgery, so that might be, for example, urgent vascular surgery, and of course those patients having obstetric surgery, and that relates predominantly to elective caesarean sections. The biggest risk factor on an individual patient level for last-minute cancellation was the requirement for a post-operative critical care bed. And so that in itself tells you the importance of understanding both capacity issues, but also whether or not critical care is actually potentially a benefit to a patient, because the last thing that we would want is for patients to be cancelled on the basis of needing critical care after surgery, when in fact that wouldn't necessarily be of benefit to them. If you look at hospital level impact or reasons why patients might be cancelled, the 2 biggest associations with last minute cancellation were having your surgery in a hospital with an emergency department and having your surgery in a hospital with an enhanced care unit. Now I'm going to come on to talk more about enhanced care units in a moment. My impression is that the reason that that was a predictor of last minute cancellation is that those cancellations occurred in hospitals which had already identified a risk of not having enough critical care capacity and therefore had created enhanced care wards in order to try and reduce the risk of last minute cancellation, but they didn't necessarily completely cut out that risk. So the next set of questions that arises from these analyses are, what do we do in order to solve these problems? What's clear to me from looking at the data in detail is that we need system solutions. It's not just about necessarily providing more beds. some of the things that we could consider, for example, would be reconfiguring services or ring fencing of beds. The obstetric case was a particularly interesting one to me. We all recognise that most obstetric units are ring fenced. They are self-contained units which have their own operating theatres, their own staff, and they do both a combination of planned care, such as elective caesarean sections, and really, really high-risk sudden emergency care, such as Category 1 emergency sections. So, because we identified the fact that obstetric patients were so much less likely to be cancelled, I think that's an interesting case to look at to see whether or not we can learn something that can be applied more generally across the board. But we really do have to focus down on whether critical care in its current form provides benefit, because we recognise the fact that post-operative critical care requirement is a risk factor for cancellation. And a secondary important question is whether, if there is a benefit to critical care, whether that benefit could be conferred through provision of a different type of enhanced post-operative care without necessarily the need to go to an intensive care unit. So on that basis, we also then investigated what the provision of post-operative high acuity care was to patients in the UK, Australia and New Zealand. In this study, 309 public hospitals took part, of which 92% reported on-site critical care facilities. And in the 3 different countries, the number of critical care beds per 100 hospital beds was roughly similar, but you can see that the number of critical care beds per 100,000 population and the number of ventilated beds per 100,000 population differed quite substantially, with Australia having a much higher bed-to-population ratio than the UK or New Zealand. That, I guess, may in part relate to some of the distances in Australia being so much greater. If you look at the general ward staffing, so these are normal hospital wards, not critical care, not enhanced care, you see an interesting pattern emerge again, where the United Kingdom has a much less favourable nurse-patient ratio on its normal wards than Australia or New Zealand, both at day and at night. We were interested to find out more about enhanced care wards. We were aware, we'd heard stories that enhanced care wards existed, but what characterised them? We defined enhanced care for the purposes of this study as wards outside critical care and operating complexes, which offer some aspects of critical care, but not necessarily all of them, and have a higher nurse-patient ratio than normal wards. And what we found was a few interesting things. So the first thing was that where these enhanced care wards existed, they were predominantly led by surgeons rather than anaesthetists or intensivists or physicians. They were able to provide a variety of different interventions, but the key common characteristic was that they were able to monitor patients continuously, ECG monitoring, blood pressure monitoring, and so on and so forth. And the other key thing was that the patient-to-nurse ratios were much higher than normal wards, and actually equivalent to high-dependency units or level 2 units. The third study we did was a clinician survey to understand what clinicians felt about post-operative critical care versus ward care. And I'm delighted that this study, which has been led by a medical student, the analysis has been led by a medical student, Sophia Hashim, has just been accepted for publication in Anaesthesia Journal. And perhaps the most interesting aspects of the results of the study come through in the free text comments that we received. And the perceived benefits of post-operative critical care fell very clearly, to me, into 2 major categories. The opportunity to monitor patients more closely, as in the physical technological monitoring, and the second was the higher nurse-patient ratios. So here, a few quotes from consultant surgeons and anaesthetists with a lot of experience behind them, explaining what they felt the perceived benefits to be, and here further comments about the value of the higher nurse-patient ratios than are achievable on normal post-operative wards. Now, that's all very well and good, and wouldn't it be lovely if we could offer that level of support to every patient? But I guess 2 things are important to consider there. The first is it isn't going to be possible to provide that level of input to every patient after surgery. And the second is that probably it's not necessarily going to be of value to every patient. So patients having relatively minor surgery wouldn't necessarily benefit from that enhanced level of care. So how should we select patients for surgery? So that was one of the main questions that we were asking of the patient study, which was how should we predict post-operative risk? We have guidelines that say that every patient with a 30-day mortality predicted risk of 5% or greater should go to critical care after surgery. But what the guidelines don't tell us is exactly how we should predict that risk. So that's what we were trying to do with this study, which has now been accepted for publication in PLOS Medicine journal. So over the week of the study conducted in each country, we included every patient that was did not opt out of the study, undergoing inpatient surgery, so requiring an overnight stay, and we loosely defined that as a procedure that required anaesthetic support. We wanted to compare risk prediction methods that were openly available to everyone. So clearly exercise testing is neither available in every hospital, but more importantly, it's not something that's available to emergency surgical patients. So we wanted to look at only things that could be applied to every patient, irrespective of where they were treated and under what circumstances they presented for surgery. So the way of doing that was to identify a few well-known, well-validated previously or new risk prediction tools, and the three that we focused on were the EPICCS, the surgical risk scale and the surgical outcome risk tool, and evaluate and compare their accuracy. And the next thing that we wanted to do was compare how accurate these methods were with clinicians using their own clinical judgment about what the patient's 30-day mortality risk was. And so with every patient, we asked the perioperative team looking after them to predict what they felt their 30-day mortality risk would be. And the results of this study, so about 26,000 patients were recruited in total, and our analyses focused on 22,000 patients. We excluded the obstetric patients because there were thankfully no deaths in that group. And so we excluded them as a low-risk population that in this cohort would add no value to the analyses. We undertook several different analyses looking at both the validity of the objective models that have been previously described and also the clinicians' predictions themselves. So the first thing to look at is whether this was a generalisable population, and it's the reason that we were very keen to make this a non-consenting study was to avoid any potential risks that might be associated with a recruitment bias, which in particular might mean that high-risk patients were not recruited into the study. So of the patients that were recruited overall, we found that there was a good spread of patients across the different ASA grades, about a 60-40 split between women and men. 57 years of age was the median age, and a variety of procedure severity, but weighted more to the higher end of the spectrum, as one would expect for a study of inpatient surgery. We also conducted a number of analyses in a high-risk subgroup, and this was defined on the basis of previous studies, such as, for example, the VISION study, which articulated a high-risk subgroup on the basis of comorbidities and age. And if you look at the different surgical specialties involved, again, a good mix of different specialties across the board. As I say, we dropped the obstetric patients from the analysis, and a broad range of different comorbidities, which, of course, were more prevalent in the high-risk group. The cohort characteristics, if we look at the 30-day mortality, overall, this was 1.2%. And the important thing about this is that it was similar to the real-world mortality as evidenced by looking at administrative data, which was available to us from this paper published in 2017. So our overall cohort and our restricted subgroup of high-risk patients both match roughly to what we consider high-risk patients to be through epidemiological administrative data. We wanted to know how clinicians use risk prediction tools in general, and we found that the vast majority of cases, clinician judgment was the predominant way in which people assessed risk. There was a big group of people who used the ASA score, but very, very few patients had their predicted risk based on any of the objective scoring tools that are available, including the broader spectrum of tools and methods such as exercise testing and frailty assessment. So what we found in the past, this is from an editorial published some years ago, was an assertion that despite the fact that there are a huge number of risk prediction tools out there, that we use very few of them regularly in practice, and we certainly found that to be the case. When we looked at the three different models that we wanted to evaluate, we found that the calibration, so how well the observed expected ratios matched up, to be pretty poor, particularly at higher end of risk. But of all of them, the surgical outcome risk tool performed the best in terms of calibration and discrimination. If you look at how clinicians predicted outcomes, actually clinicians are pretty good at lining patients up in a row, so discrimination in terms of risk, but we're terribly glass half empty when it comes to whether or not that patient has a particular risk of death. So we vastly over-predict 30-day mortality. What we then did was look at a combined model which combined the surgical outcome risk tool assessment with the clinical judgment to see if it conferred any additional benefit in terms of prediction. And it does. Clinical judgment and the sort were roughly equivalent, but the two combined together yielded a more accurate prognostication of surgical risk. So, the summary of that is that if you combine clinical judgment with an objective risk tool, you probably get the best possible prediction of outcome, and and that type of method will predict with a very high degree of accuracy, lining patients up in a row, so the discrimination between different patients in terms of their perioperative risk. So what do we know from all of this now? We know that we probably don't have enough critical care beds at the time that we did this study to meet demand for surgery 24 hours a day, 365 days a year across the United Kingdom, because we do see some last-minute cancellations that are related to capacity issues. We know that the main value of critical care after surgery is thought by clinicians to be continuous monitoring and higher than ward nurse-patient ratios, which is important because what people didn't say is, oh, it's because we can electively ventilate people or we can give them this particular type of fluid or drug therapy. It was more about the monitoring and the nursing ratios, which might therefore lend itself to thinking about whether enhanced care units, which have organically sprung up as a result of trying to meet increased demand for post-operative higher acuity care, could provide some of the answer outside normal critical care facilities, and therefore potentially reduce the risk of cancellation and offer a higher degree of care to a bigger number of patients. And then the final thing that we've summarised so far is that we can predict 30-day mortality risk reasonably accurately, but what we need to do now is really apply those methods in practice in order to risk stratify patients to the correct level of care after their operation. So the final big question from this study was whether or not critical care actually confers benefit for patients. And the answer to this is yes, it probably does. When you look at whether or not critical care is associated with a better outcome normally, the analyses are undertaken using regression analyses, and these are usually thwarted by this problem of confounding by indication. So it always looks as if critical care is bad for patients because patients are more likely to die if they're in the critical care category. But we know that that's most likely due to the fact that patients are higher risk if they go to critical care. We may not necessarily be able to measure that using tools that we normally use, but there's something that the clinician identifies of making the patient high risk that means they end up in ICU. There are some advanced regression analyses, causal inference analyses that can be conducted which address this problem of confounding by indication. And there's an abstract here at EBPOM, which has been undertaken by our medical student Tarush, which will give you the results of a causal inference analysis of this data set, which is very exciting, I think, in terms of understanding what, if any, benefits there may be of critical care after surgery. But I'm not going to steal his thunder. So, to wrap up, what is critical care? Well, I guess it's all of these things. It's a place of higher level nursing care, 1-to-2 or 1-to-1, according to the guidelines for the provision of intensive care services published by the Faculty of Intensive Care Medicine. It's a place that we can do clever monitoring, it's a place that we can give clever drugs, and it's a place where we can use clever machines that go ping. But what is enhanced perioperative care? According to clinicians, the value of this might be in the higher acuity nursing and medical input than normal wards, but not necessarily as high acuity as HDU or ITU. It's a place that we can do continuous monitoring. I would say that clinicians generally think that that is one of the big values. Is it the place that we can give some clever drugs? Probably, yes, but perhaps not the full armoury of what we can offer in critical care. And is it the place that we can use clever machines such as mechanical ventilation and so on? Probably not for enhanced perioperative care. And therefore that does offer the opportunity for us to rethink whether or not we can expand the provision of this type of care outside the normal footprint of critical care and therefore offer value to a higher number of patients. Because what we know is that despite looking and looking and looking, there really does remain some equipoise over whether things like preemptive respiratory support, hemodynamic optimisation and so on, specific interventions, offer any benefit to high-risk surgical patients. So what's in the secret sauce? I suspect it's really good high-quality nursing care and continuous observation and therefore early detection of post-operative deterioration. So our next big challenge arises not just from the landscape that existed when we conducted SNAP-2 EPICCS, but the new landscape that we're now living in as a result of coronavirus. So critical care probably does need to be expanded in the United Kingdom and potentially other countries where COVID is likely to be endemic in the short term. But we have a finite workforce, and so we can't suddenly just augment the number of critical care beds very quickly without rethinking how we deliver it. So could we deploy our workforce more effectively? Does every patient that currently goes to intensive care for high-risk surgical after high-risk surgery actually require a 1-to-1 or 1-to-2 nurse-patient ratio? Or could that care be delivered to the same level, the care that would benefit them, with a lower nurse-patient ratio and different focus in terms of consultant and medical support and allied health professional support? In the brave new world that we're living in, working in intensive care units, so level 3 intensive care units where there could potentially be a lot of COVID, where there's the need to wear personal protective equipment all the time, these are going to become increasingly hard places to work. And therefore, rotating staff between units like that and higher acuity than ward care, but perhaps lower acuity than level 2 or 3 care may be beneficial to staff in terms of well-being and resilience, and to the system as well, because it may encourage us to train a broader number of staff in at least some of the basics of critical care nursing and medicine, and therefore again confer that benefit to more patients. So providing enhanced care for surgery might provide us with an important opportunity to both expand the number of beds that are available to look after patients who are at higher risk than a basic level 0 patient who needs to be in hospital for a few days of relatively low acuity treatment. But one of the big unanswered questions is what level of clinical staffing, both in terms of the expertise of the staff, the ratios and so on, what level of staffing do we need to provide to still offer benefit to patients having high-risk surgical procedures that don't necessarily go to an intensive care unit? So to wrap up, I'm just going to reflect back on the 3 aims of SNAP-2 EPICCS. So the first was to analyse the epidemiology of critical care after surgery, and I hope I've given you a reasonably comprehensive run-through of our results I hope, assure you that we've done that pretty comprehensively. We wanted to engage clinicians in research, and we wanted to support trainee leadership and delivery of major research. And I'm really delighted that we, I think, have achieved those ambitions as well. So far, there are 6 manuscripts either published or in the pipeline, so the protocol paper and 5 results manuscripts. 3 of them have been published by Danny Wong, who, at the time of recording this video, is about 3 days away from his PhD viva. So by the time you see it, I hope that he will be PhD positive. I'm sure he will be. And really brilliantly, 2 first author papers by medical students. So Sophia, who led the clinician survey analysis, and Tarush, who's been leading the instrumental variable analysis, which is currently in preparation and is being discussed here at EPICCS as a finalist in the abstract competition. But again, the big success was the collaboration across the UK, Australia and New Zealand. More than 3,000 collaborators participating in the study, giving their time and their energy to the study and helping us undertake what I hope will be important analyses that will help us understand how we should be providing care to the highest risk of surgical patients. And so I'm really incredibly grateful to you for that collaboration, and to you also now for listening. Thank you very much.
Top Med Talk.
Thanks for downloading Top Med Talk. Don't forget to subscribe via your podcatcher. Don't forget to check us out on social media. We're on Twitter, Facebook, LinkedIn and YouTube. And also, don't forget, Top Med Talk is the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. We'd love you to find out more about that. If you check out ebpom.org, you can find low prices on some of the conferences we're organising around the world. Many of them are virtual and don't even involve you leaving your own home. Check out ebpom.org now.